my name's Charlotte Pawlyn. I'm a haematologist from the Royal Marsden Hospital and the Institute of Cancer Research in London, and I'm here at the IW GPRC5D meeting in New York. I'm joined by two colleagues who I'll let introduce themselves.
Yes, hi, my name is Sridevi Rajeeve. I'm part of the multiple myeloma and cell therapy team at Memorial Sloan Kettering Cancer Center right here in New York, where this IW GPRC5D conference is being held for the second time, and we are having great discussions, which we hope to continue in this session.
And hi, I'm Omar Nadeem. I'm from the Dana-Farber Cancer Institute myeloma program in Boston, Massachusetts. Glad to be here.
Great, thank you. So perhaps you could summarize what some of the discussions we've been having so far around GPRC5D-directed therapy in terms of what we're seeing in terms of responses and duration of responses with some of these new approaches to treatment.
Absolutely. I think, since Omar recently just gave a talk on that, I can maybe summarize what happened yesterday in our session. So, yesterday there was a lot of focus regarding basic science and translational science with a specific emphasis on diagnostics, So, what tools do we have in our armament to really go after GPRC5D? Because GPRC5D testing is not really that available or yet scalable, and therefore for many institutions it's really hard to really determine if a patient has had a GPRC exposed agent before, do they have retained expression, and if there is retained expression, is there a mutation present? And all this helps in sequencing. So there was a very robust discussion regarding methods of detection, how they can be scaled, and I think that has a lot of practical implications, not just academia, but how we can make it available to the community within the US and ex-US and hopefully more. So I think that was a great start to the conference. And again, just pivoting to the clinical perspective, where we have multiple modalities that are now directed against GPRC5D. We have CAR-T products, which are single or dual antigen targeting. We have antibodies, which are GPRC5D directed, mono, bispecific, and now trispecific. And now we have ADCs, which Omar just recently talked about, which is in clinical development. So there's a lot of data that is coming in with, really good PFS, and overall survival data is still yet not mature, but, we are seeing decent PFS that is really following along the tail of BCMA-directed therapies. I think it's getting there, but it's really amazing that we have a separate target we can go after. We have exhausted probably BCMA-directed therapy. So that's just a summary, and feel free to add on, please.
Yeah, and I think the responses, have been phenomenal. You see the data already with Talquetamab, which we're using in clinic. You see about 2/3, about 70% of patients respond to Talquetamab. And the duration of response can be several years for some patients that are doing well on that drug. And then it was really exciting to see the data from Arlo-cel, which is our GPRC5D CAR-T cell product. In that phase 1 trial, about half the patients had prior BCMA therapy, and we tend to see no detriment to response and a very similar PFS in that cohort as we do with the non-BCMA exposed patients. So I think it's just giving us some clues that these are therapies that we can potentially sequence, because it is a different target, as most patients now have had prior BCMA exposure.
And regarding at least publicly available data regarding the combination of teclistamab and talquetamab in the redirect trial, and also the trispecific antibodies, again, we are seeing robust responses. For specific cases, the NCCN now allows the use of teclistamab and talquetamab for patients with bulky disease, including extramedullary disease, and they have a really overall response rate close to 80% and no real increase or additive increase in toxicity despite the combination of BCMA and GPRC5D. And that is something that we have started using in our own clinics. We're not getting significant pushback from insurance because it is in the guidelines. So again, excellent responses and safety signals with this target.
Great. Perhaps you could tell us a little bit about what some of the side effects are that patients experience, and maybe a little bit about how that should impact how we understand those toxicities. What measures can we use to find out from patients what they're experiencing in terms of toxicity?
Yeah, so when this target was first discovered, we learned that, it is universally expressed for the most part on plasma cells, but there's some other areas of the body where it has expression, which can impact, some of the toxicities. So this was particularly noted with Talquetamab as that data was first coming out, these, so-called on-target off-tumor effects where patients started reporting some dysgeusia, dysphagia, and some of these, symptoms that do have some quality of life implications where they lose their taste and they're having some weight loss as a result and not able to eat. And then over the years, I think we have, acknowledged this side effect, but also have now tried to mitigate it. So, kind of using some dose modifications and adjustments in patients that experience some of these toxicities, and our dosing for Talquetamab, for example, can be relatively infrequent now for patients that have had some of these symptoms, that you can dose reduce and give it, perhaps monthly and not necessarily lose a response, but certainly allow them to tolerate this a bit better. So every CAR T or ADC or anything that targets GPRC5D that's now in development, we're always looking for these similar toxicities. And it's, there is a kind of a class effect there for sure with this antigen, but there are differences, I think, between the different modalities. So in the CAR T program so far with Arlo-cel, we're not seeing that to be as much prevalent as much, and especially not in higher grades, and it's definitely more transient. But we are seeing some other signals of these other select neurotoxicities that are reported in that CAR T-cell trial so far that manifests with either dizziness, ataxia, balance issues, and things like that, again, in a small fraction of patients, and probably dose dependent based on some of the data that we've seen at this meeting and other meetings, but something to monitor going forward. So I think there are some unique toxicities associated with this antigen, and they can certainly have quality of life implications, but I think we're learning a bit more about how to mitigate it and hopefully how to prevent it in the future.
A practical, point that as practicing clinicians we can all do is to try to involve your oncology pharmacist early in the treatment paradigm. Again, they have been an integral part of whenever we have any patient on Talquetamab, and we prophylactically give them saliva substitutes for mucositis, emollients and bland creams for protection of skin. And again, there are certain interventions you can do for taste changes as well, because they are very significant, leading to weight loss as well, which is often a big reason why we stop these medications. So, involving a pharmacist, identifying the side effects right at the onset and then acting on it immediately can try to really help.
Yeah, I think you raise a good point. There are lots of people to kind of around who work around us who can perhaps help: dietitians, pharmacists,
yes.
Other people who can contribute to the patient care. Okay, so perhaps we could switch tack slightly and talk a little bit about mechanisms of resistance to these drugs. So we've heard some fantastic talks over the last 2 days from various different people reporting their findings on this. So perhaps you could maybe revisit some of the most common mechanisms that have been identified and some of the ways in which people have been talking about how we can identify those in patients.
Absolutely. So, there's a lot of work that has been coming out in the last 2 years, but just to summarize, and we had a fantastic talk by Dr. Ballas this morning about ongoing work in his lab and collaborating across the continental US, I believe. There's always the issue of antigen loss that has been apart for whichever target that we are targeting. And Dr. Ballas also demonstrated that it's not just necessary that the antigen loss can be after exposure to a drug. It can happen right at the onset as well. And there was an elegant experiment that showed both antigen loss of BCMA and GPRC in treatment-naive patients as well as for patients who received the treatment. So antigen loss, or losing the target either from the beginning or after exposure to a drug, is a significant resistance mechanism. And other mechanisms, obviously, again, mutations that are acquired along the way that renders, so you have the presence of the gene, but then it's rendered inefficient. They can't really translate into the required proteins because of mutations. So that is also another resistance mechanism that we are seeing. Again, there is loss of expression of antigen on the surface and many other mechanisms that we are finding out, but again, how do we get past them clinically? And these are going to be part of clinical trials that are going to be designed in the future, as well as translational studies.
And we heard, Omar, a little bit about, I guess, by the end of yesterday, I wanted to be able to do flow cytometry for GPRC5D, IHC for GPRC5D, but also in-depth mutation analysis. How far away are we, I guess, from having some of those accessible to us in the clinic?
Yeah, I think the technology is there. It's really more about just standardizing it and trying to understand how that impacts potential decision making in response to therapy. I think that area is not yet clear. So IHC, is reported as kind of weakly positive all the way to strongly positive, which has some interpretation naturally there. And then flow cytometry, again, the assays they look pretty reliable. But again, at what point do you use these? Do you use these at the time of diagnosis to kind of identify who has this present or not, or do you do it at a biopsy at a time of relapse, biopsy an extramedullary site when you're making treatment decisions, and then which of these modalities you'll use, I think is still a work in progress. But hopefully over time we'll have all this data available to us because we have so many of these therapies, many times targeting very similar antigens, and it'd be really important to kind of get more of a real-time analysis or an update as to kind of how these things look. And then going back to the resistance, question, it was interesting to see that you tend to see more GPRC5D loss than you do, BCMA, which I think is really critical because ultimately, we may be able to cycle perhaps more BCMA therapies, but we may not be able to cycle as many GPRC5D therapies. So it's really critical, to kind of choose which one you will for the patient. If we have a few of these available in the clinic and they all have some of their, differences as we just talked about. And the final point there is T cells, right? I mean, we're so focused on the antigen, but many of these therapies are using the same exact T cells to attack, myeloma, just using a different antigen. And, T cell exhaustion is always a big topic, whether that's more impacted by bispecifics or CAR T or whatever, and we still don't really have the best tools in the clinic for me to be able to say, okay, your T cells are at 50% or 80%, it's just more that, I hope that over time we have something that gives us that kind of information.
I think just pivoting, back to the question you asked, I'm curious in your institutions, where are you guys with GPRC5D diagnostics? I can share at MSK, initially for the last 2 years, we had to email our pathologist to say, can you please add on GPRC5D? It was not part of the standard protocol. We've had BCMA reporting in all BMAs for maybe the past 2.5 years, and GPRC used to be at request. However, with the concerted effort of Dr. Malakuri, we've now had more GPRC5D reporting without us requesting for it. And I know that's not something that's easily available. For patients who come for second opinions, we often get requests from local oncologists and collaborative oncology colleagues to do the BMA here so that we can have BCMA and GPRC5D expression information from MSK. So, we're slowly scaling up, but I'm very cognizant that this is not something available. So I'm just curious to see how things are.
And you're doing this by flow cytometry or on bone marrow
IHC now? IHC. And Dr. Dogan is, I believe, very close to formalizing and finalizing the flow cytometry as well. But so far it's IHC, and it's reported as, again, week plus or 2+, which is helpful for us. Again, we don't actively look into, mutation status, but at least it's helpful to know. And because we've had surprises where, GPRC right at the onset is very weak. So that's in a way guiding us as to what therapy to choose. But again, lots of way to go. So I often wonder of how it's done at other places as well.
Yeah, I think we're just getting kind of started, kind of standardizing this reporting as well, just like you are. So kind of incorporating it into the biopsies, both the BCMA and GPRC5D. But up until this point, it hasn't been, universally done on those samples. But again, over time, hopefully that'll be standard because it is going to impact our choice of therapy.
Yeah, I think we have a similar kind of in development timescale at the moment, and partly driven by the fact that in the UK we've had access to Talquetamab clinically probably for less time than you have here, and so obviously the kind of the need for diagnostics comes after you have clinical access to make decisions based on them. But I think also from the talks we had today, it's important that expression could be there, but there could be a mutation, you could have loss without a mutation, so you could have epigenetic loss of expression. So I guess what we really need is in order to make kind of confident clinical decisions, we need to combine the modalities to be able to see all of those aspects. Okay, and then if we are thinking about overcoming the resistance once it's generated, we talked a bit in the last session about should we be targeting 2 different antigens simultaneously? Should we be doing that with 2 separate bispecifics or in a trispecific format? Or should we be sequencing these agents one after another? So perhaps you could give us your thoughts, especially if as you now have access in some cases to the combination of targeting both antigens simultaneously. How do you think about that clinically?
I think the preliminary data so far that we have with the trispecific antibodies, and even some of the dual targeting CAR T cell therapies looks really good. I mean, you see very high, robust responses, deep responses, MRD negative disease, even in heavily pretreated patients. So that gives me hope that the combination effect right from the get-go is going to be the way to go. Now, how durable is that going to be? What that's going to do at the time of relapse from some of these agents? I think that's really the critical question, because right now you may be able to kind of go from one to the other because they're different enough. But here, like we've done in the past with all myeloma therapies, most of the time when you combine some of these targets right off the bat, you tend to have way better outcomes and much more durable responses. And then at that point, there's newer strategies, usually available, which is historically what's happened in the last 10 to 15 years. So I'm in the camp that I think giving, two of them simultaneously, whether it's in the same construct or just two different agents at the same time.
And we're doing some translational studies. We have all these dual exposed patients at MSK, so we're doing translational studies to really understand, to quantify the antigen loss, with respect to monotherapies in multiple modalities. So, we should have answers in the next couple of years, but I think it's still evolving, and sequencing will remain a big challenge.
Great. Well, perhaps we'll leave it there on that forward-looking note, and thank you very much for joining me today.
Thank you.
Thank you.